My talk about staging and progression. Should we depend on structure or function? What is the value of each? Is anyone is more important than the second? Diagnosis of glaucoma depends on so many factors. My talk will depend on only these three: the OCT, the field, and the disc. To stage the amount of damage is important because it's one of the factors that will help us choose the target IOP. So we need to categorize our patient, is it a mild or moderate or severe damage. Other factors can be included and should be included, but just this part is part of the parameters. Sometimes people depend on the field of vision or the optic disc or both. There are so many systems like the old one of Parrish Anderson back to 1993. And then we have these two systems, the American guideline and the Canadian guidelines. Later there are other systems like the glaucoma staging system 1, glaucoma staging system 2. I'm going just to keep an eye on the American and the Canadian guidelines. The American guidelines classify the amount of damage as that. Early glaucoma is a patient with characteristic optic disc anomaly and the field is totally normal. White on white field is normal. Moderate glaucoma is a characteristic optic nerve anomaly with field anomalies in one of the two hemispheres, either up or down, and no affection in the central 10 degrees. Severe glaucoma means affection in the field up and down or affection in the central area. As you can see, they just get the optic disc anomaly out of the way. They depend totally on the field to put the patient either as a pre-perimetric glaucoma in the early stage or moderate or severe glaucoma. So if you have it here, this is a totally free field, but with disc changes. They consider this mild or pre-perimetric glaucoma. Moderate if you have changes in one of the two hemispheres, but the central part is not affected. In case having affection up and down or having affection in the center, then this is a severe. If we come to the Canadian guidelines, they defined early glaucoma by having field changes. They describe it as early field loss together with mean deviation less than 6 and cup disc ratio less than 0.65. Moderate glaucoma, you have significant field changes. They didn't decide what is significant, but the point is the central 10 degrees is not involved. Second, mean deviation between 6 and 12. And the cup disc ratio from 0.7 to 0.85. Severe glaucoma when there is affection of the central 10 degrees or mean deviation more than 12 or cup disc ratio higher than 9. So affection in the field up and down, but not much, they consider it mild. Extensive affection, but the center is free, they consider it moderate. Affection in the center, they consider it severe. Then they add the mean deviation, and they depend on the cup disc ratio. As you can see, there is no agreement between the systems. So for me, I just have all these in my mind, and I always go and choose the severest part and go for it. Whenever I have changes in the central part, this is severe glaucoma. If there is affection up and down, I prefer to use the American type, it's severe, and so on. If you have some changes in one of the parameters and the other is not supporting, I usually choose the severest one to build my decisions on. Now, structure and function. Sometimes you see OCT changes only or disc changes only. Sometimes you see field changes only, and sometimes you see them together. When they are both together, this will increase our confidence in the diagnosis. So both structure and function help us with the diagnosis, the staging, and the progression. Before checking the field of vision or OCT printout, keep in mind these points. First, keep in mind to be free of pitfalls and errors. For example, you need to have the same field changes repeated 2 times to make sure that it is real. In this example, this is the field with the repetition, everything disappeared, so it's not real. So you need to confirm changes on 2 reliable disc examinations. This is not only in the stage of early learning curve, even all over the disease, whatever the stage is. I don't accept any changes being real unless I see it in at least 2 further fields. For the OCT, you need to make sure that the signal strength is fine, because OCT with low signal strength, you get low data. Each machine got its level of significance. Below that, you don't accept the results. And you have to memorize all these numbers. The Ceres, the Stratus should be 6 at least. The Spectralis should be 15 at least. The OptiView should be 40 at least. The Topcon should be 45 at least. Sometimes the new printouts, it's already highlighting for you in green or red or something. Again, in your mind, not every red and yellow is a disease. Simply because of the limitation of the normative data, maybe your patient is outside of all these ranges of the normative data. Again, I'm going to show you 3 articles. They were done on normal persons, and they agree that in a normal person, we may face changes in the OCT and the RNF or in the ganglion cells in 1/3 to 1/4 of the patients. This is the first study. Around 150 healthy persons, they get around the disc this appearance of red and yellow in almost 1/4 of the patients. This is one of the examples with normal disc, normal field, but the OCT have these changes. Another study showed that comparing 131 eye with glaucoma, early glaucoma, mean deviation less than 6, they get this appearance in the ganglion and the macular area in around 80%, this appearance in around 90%, this appearance in 80%. But again, in the same study, around 132 normal persons, you have these appearances in 20%, 28%, 15%. So whenever you see such a thing, don't rush for glaucoma. Again, the degree of error in that study were simple myopia, maximum 4 or 5 diopters. The third study was done on 104 patients. They found changes in the ganglion cells in 40% and in the RNF in 30%. These are some of the examples of that paper, such changes. They don't accept this as real because they are missing changes around the disc. And they advise, this is the typical for glaucoma, that the changes are temporal to the fovea. It respects the horizontal raphe, and there is a corresponding RNF changes to that area, and it is arcuate or crescent in shape. If you have all these data, then you are sure more that it's a real thing. Again, this was the first point. The second point, check for asymmetry. Glaucoma is typically a bilateral disease, but frequently asymmetrical. Visual field and OCT defects are commonly asymmetrical at the time of diagnosis. Asymmetry can be between right eye and left eye, and asymmetry can be between inferior half and superior half. So keep in mind any presence of asymmetry. For example, in the OCT, you get a comparison between right and left eye. This is abnormal. Or even in the table here, you can find this parameter, are an asymmetry. Again, in the optic view, you have right and left eye, and the difference is shown up here. And even in the spectralis, they are comparing right to left, and this part, they are comparing these with those, and each one with the similar on the opposite side, and you have this clue, right to left comparison, and on this side from left to right. In the lower part, they are comparing inferior to superior, that is for this eye, they are comparing this row with that, the next one with that, and so on. And in the upper half, they are comparing from up to down. So this will draw your attention, there is something is going on. In this example, I've got it from the internet. The author there, they show that there was asymmetry between in the right eye, between the superior and the inferior. Although everything looks fine, everything is perfect, then on the examination, there is hemorrhage, and in the field, there is field changes. So this is a green disease. If you can miss it unless you check this point of asymmetry. Again, in the Humphrey, we get the glaucoma hemifield test comparing each sector with the corresponding one. If one of these sectors, the difference between the one up and one down is found in only 1% of the normal population, you get this term outline normal limits. If it's present between 1% and 3% of the normal population, you get a borderline. So the third, you need to check for areas constant with the glaucoma. In the field, glaucoma can be present as a generalized depression, but usually it is very rare to be alone. Paracentral scotoma, sometimes we have difference between me and my friends, doctors, where is paracentral? So the central the central 4 points, this is the center, and outside it, I consider it paracentral. In this example, this is a little bit out. It's the third one from the center, so it is somewhere between say 9 degrees or so. The third is nasal step. The definition of nasal step is you have a relative depression in one of the two hemispheres. Like this, you have changes in one side and not in the opposite side. This is nasal step. Like in this example. And again, being up, nothing down, this is nasal step. Arcut or germ scotoma changes between 10 and 20 degrees. This is the blind spot, so we follow it. Again, this is arcuate, but it's getting paracentral as well. Lastly, altitudinal defect is one of the things of glaucoma. If the arcuate getting to the center, paracentral, and central. So again, this is one of the possibilities. In the octopus, they put the test points in special location following the nerves, then they can diagnose glaucoma. And in the new software, they depend on clusters. They collection of points together and add them and compare them with the normal population. If the addition result in a low probability, then it is highlighting for you. This is area, get a probability 1% or 5% and so on. In the OCT, where are the points to look at? We need to look at the average retinal nerve fiber layer thickness. This is the highest parameter to diagnose glaucoma. Then clinicians should look at the superior and the inferior rim. This is the second frequent area. Again, if you examine the macula in the OCT, If you have a lesion that is respecting the horizontal raphe, this will lighten the possibility of the glaucoma very much. Again, Hood et al. They documented this area just temporal to the fovea, arcuating like this, and they found the affection of this area is very commonly affected or associated with changes here in this area of the disc and the parapupillary nerve fiber layer. And they call this part macular vulnerability zone of the disc. So this area, if you have changed in it, consider most probably you have changes as well here in the macula. And they say that this location is a very common location for the occurrence of hemorrhage, disc hemorrhage. Further group, they published again in 2017, and they show that all cases with affection in this area of the papillary nerve fiber layer were associated with changes here in the macula. On the OCT, you can check it here. This is the area to check for that location, or in the map you can find it here. Again, if you have changes in the macula going on with the changes on the around the nerve, then you are more certain of the diagnosis. And recently you have a printout of both zones. Here this is around the disc and this is the macula, and there is changes and they are following together. Although the retinal nerve fiber layer alone, you can only have some changes here, and the ganglion cell inner complex layer, everything looks green here, but this is a sign. So as you notice, not everything should be appear together. Any one title thing will push you to the possible diagnosis. Lastly, you need to correlate between the visual field and the OCT. You have to know the anatomical locations. This is the famous work of Gerway back in 2000. He located the 24-2 of the Humphrey on the fundus. These 6 points, they get access to the nerve or the retinal nerve fiber layer here, and this 90 degrees. This part of the field up and this part down, they get in these 40 degrees. The up will be here, the lower will be there. Then the remaining part of the field will get into this area of the retinal nerve fiber layer. The remaining 4 points nasally will end up nasal part. So this area is the most important to keep an eye on, because this is the arcuating area for the glaucoma. So keep an eye always on this area inferior or this area superior. In the clock hour, they are there. Not exactly at the clock hours, but this is the locations of the inner parts and this is the outer parts. You have to keep this in mind. So if you have changes with several points together with the field, then you are sure more with the diagnosis. I'm going to show you some of the examples. Here you have damage in the lower part. If you check the OCT, you have changes here in the inferior. This is the nerve fiber layer. This is the neural tissue, the disc, the neural rim. And this is the macula. You get things going on here together and respecting the horizontal raphe, and the field changes going on, then you are certain of your diagnosis. Another example, the disc looks normal, OCT is fine, macula is fine, field is okay, but as you notice here, you get some changes and you have borderline, so this is a query. You need to repeat the field to keep an eye, just to be sure if for the second time field is normal, then you are safe. For me, this looks there be something here, but it is fine here. OCT is okay, no changes in the field. Another example, you have some atrophy here, striations here are missing. OCT shows change coinciding with that. Again, in the macula, it's going on, and field changes. Then you are sure of your diagnosis. I can skip that for the sake of time. Now, what about progression? We need to know what is the rate of progression. Keep this in mind. If you have your mean deviation, once it is below 14, this is visual impairment. If it's below 22, this is legal blindness. So we want our patient not to pass into this bad area by the end of their life. We want to keep them up here in all their life. Diagnosis can be done depending on event analysis or trend analysis. Event analysis means something is shining up in one location. Trend analysis is the rate of change over the time. Let's see how to do it in the field and how to do it in OCT. We should stop putting fields next to each other and say, yes, this looks progressive. No, we should stop that altogether. I want to convince you why we should stop that. This paper was published back in 1989. The author there, they got 51 patients. They were tested 4 times within 4 weeks. These patients got different severity of glaucoma between early and advanced glaucoma damage. And they found the following. Areas where the sensitivity were near normal, these areas get a fluctuation in the follow-ups in these 4 weeks between +3 to -7. Areas depressed by 6 than normal, on the follow-up the fluctuation was between +1 and -16. Areas were dropped sensitivity between -8 to -18 of the normal. They get fluctuation the whole range from 0 to the full. So each location, the fluctuation varies. If it's near normal, the fluctuation is limited. If it's more depressed, the fluctuation is higher. If it's more and more depressed, the fluctuation is higher and higher. Again, in the central area, fluctuation is minimal, while in the periphery, fluctuation is more. Third, the mean deviation of the whole field. Depressed points in a generally depressed fields show more test-retest fluctuation than similarly depressed points in otherwise normal field. بمعنى, if you have 2 fields, the mean deviation in one of them is -1, -2. The second, the mean deviation is -15. The same values with the -15 general depression will fluctuate more than with the -1, -2 general depression. So they came up with these 3 things. The sensitivity of the location being center or periphery, and the mean deviation of the field. And this was the base on which they built the progression analysis and the Humphrey. The company makes such a map and then decide for each location certain level. If this is the first 2 examinations, and this is the following examination for each point. Once one of these examinations exceeded 1 limit, you get this triangle. If it is repeated twice exceeding this limit, you get this triangle. If 3 times, you get this triangle. What is this limit? This limit depends on the sensitivity depends on the location, depends on the mean deviation. And this is what going to get. What about this x? Means that the sensitivity of this point is so depressed that the fluctuation is so high and we cannot tell what's going on. All this you cannot get it by looking into two fields. You have to depend on the machine. And again, if the mean deviation of the whole field is less than 20, then all this is not shown anymore because the general sensitivity of the whole field is less and everything is unreliable. And this is what you get in the printout. This is the first basal 2 tasks, and this is what you have in the current, and in between you get this progression line. This was done before using the mean deviation and recently was done using the visual field index. So event analysis focus on locations. It needs fewer fields to get an outcome and you get this outcome quicker. Trend analysis, it shows you the rate, but it needs larger numbers of fields to get the result. I want to show you this, what's written here. Rate of progression minus 3.7% per year. And again, you have this plus minus 2.7. This is the confidence interval. I just want to know what's that. The confidence interval means that if we repeat the same test several times, we may get a value, this minus 3.75 might be something between -1 or down to -6.4. Minus 275, if you add plus 275 to this number, you will reach -1. If you add minus 275, you will reach that. So we are not certain for sure that the real slope is minus 3.7%. It can be something in this range. What is the value of z? If this number is high, suppose that it can be, say, from +1 to -6, then you are not sure of this regression that it has a significance. This is something very difficult for us because we are not accustomed for statistics, but actually many of the values we have there are there depending on statistics, and we should have a minimal information of statistics. In this example, -9 plus -2. So actually we are confident 95% that this curve or this line can be somewhere between -0.7 to -1.1. I just added minus or plus 0.2. Same here. This value can be varies between -2.5 to plus -3.5 by adding minus or plus half to this value. In the octopus, they making in the new software, making clusters and then following the clusters. If the variation between one visit and the following is occurring in 1% of the population, then they highlight in this is abnormal and this occurs in only 1%. This is abnormal, occurs in 5%. This is increasingly high and so on. So as you can see, if you depend on the machine, you will get information quicker and more certain. With some of the data, actually you cannot do it by looking at the two fields next to each other. They got some parameters again with trend lines. Okay, progression, it is not sure what is the value of regression slope and what is the probability consistent with progression. They haven't agreed for that. And they haven't agreed whether they should be the changes on the fields next to one another or maybe one field on, one field off. Also, they have not agreed how many points should be included and how many points, whether they should be touching one another or not. So they haven't agreed at all at what is the optimal thing for the progression, but still all these algorithms, although not standardized, still are very useful to give us a proof of progression. Now, what about the OCT? You need, if you want to check, if you are comparing numbers, you have to be sure that the change is not due to inter-test variability from one test to another. Aging is not a factor important for us because we repeat the OCT every year and the changes is usually half a micron or so, or less than that. So we just concerned about the inter-test variability. So what is the real progression? I borrowed this slide from last week talk of Dr. Karim. He was showing the Zeiss, and he showed us if you have an average, this is the inter-test variability. So if the changes is more than 5 or 6, then this is most probably progression. If you look for the hours, you need changes to be more than 12 to 15 microns. This is for the Zeiss. Let me complicate things for you. For the OptiView, this is one of the articles in the net. For the average, you need at least 5. For the superior and the inferior ganglion cell complex, you need 5. For the quadrants, you need something between 7 to 10. But this is one of the studies. If you search more for another study, you will get some different numbers. For the spectralis, for the retinal nerve fiber layer, you need changes more than 5. For the macula, you need changes more than 5. For the neural rim in the disc, the Bowman's membrane, the Bruch's membrane opening, minimal rim widths, you need changes more than 13. Another study showed that faster changes than 1 micron is likely progression of glaucoma. They were talking about the retinal nerve fiber layer. Another study recently, still not even available, it's just online. They show the degree for the spectralis changes. Glaucoma progression is slow if it's less than 1. Between 1 and 2, it's moderate. Between 2 and 4, it is fast. More than 4, it is catastrophic. So here, this study shows that more than 4 is catastrophic. And here, they accept more than 5. So what to do? Do we have to summarize all this in our brain? If we depend on the machine can highlight in that for you. One of the things in the spectralis, they compare two fields and they give us a change in the map, and as this change is showing arc width in this location, then we are more certain that this is more change. Again, this is over the time. You can see there is changes, and this is, you can see it here, baseline 1, baseline 2, and current. And if the current here is, this is the blue one is depressed here and it's highlighted there for you, and you get the regression line for the thickness, the cup disc ratio, the superior, the inferior, and sometimes even here they give the answer to you. If it's possible loss, you get a yellow sign. If it's most likely happened several times, you get red. But notice here, possible increase. Sometimes you get a sign that there is increase in the thickness. How is that? This is an artifact of the technology. Again, another machine showing the same with the change over the time with the regression line. So to end up, I told you glaucoma diagnosis depends, it's a puzzle. This puzzle depends on many factors, but even these two factors only, the OCT, the visual field, the disc, each one of them, again, it's a puzzle. If you get so many things, if you had so and so and so, most probably the change in the OCT is real. If you have that with that and that, then the change is there. Because so many people ask us, okay, give us a flow chart. If you find this, we'll do that. If you find this, we'll say that. It's never like that. You have to spend so much time for each of the machines available, we should depend on the machines. This will give us more accurate results and it will save us our time. But you have to avoid pitfalls and wrong interpretation, and also you have to have a reasonable background of statistics. It is not difficult to achieve, but this will help us a better perception of the result. I advise you, I have 3 presentations on statistics. If you check my YouTube channel, just write my name on YouTube search, then check playlist, check field of vision, then you have these 3 last presentations, statistics behind the field. Each is around 12 minutes. No equations, nothing fancy. For me, I'm an ophthalmologist, but I'm using a simple English language that will help us understand the statistics, and I invite you to